I think people-powered health is about how to use the power of people, either as individuals or families or communities or networks, to try to improve health and to do whatever it takes, whether it's to do with high-end policy or whether it's really to do with something very close to home, something an individual can do or something a community can do. And I think what's been demonstrated, particularly today, but also in other work, is the huge power that people can mobilise in order to make headway now on improving health for us all. I think one of the most important considerations is how to mobilise individuals who have never been mobilised in this capacity, but also how to translate that into political will for change, which does require a certain volume of organisation and a certain way of organising to get political messages through to decision makers. I think there's a number of challenges when it comes to scaling up or spreading known innovations. The first thing is, do they work or not? And there, I think, the more complex the innovation, the more difficult it is to understand whether it works or not. It takes time, it's a complex innovation, there's context to consider, which may be different in Sunderland to Southampton. So all those things matter. Gathering the evidence is often very difficult, and the methods we have to gather the evidence are pretty outdated. We're still using a scientific method that actually should be developed further. So that's the first point. The second issue is then how to scale itself in practice. And there, I think, we still have a mindset whereby the innovation equals impact, but it's innovation plus context equals impact. And we pay insufficient attention to what the context is in order to spread something. So there's a lot of talk internationally about frugal innovations, taking innovations from China, seeing if they will work in London, for example. There's a lot of discussions about new methods of disease management in the US, how that could impact in the NHS. But those discussions are, again, acontextual. They do not consider the context often in which these innovations have been successful in their home countries. And until we really get serious about that as an endeavour, as an area of inquiry, we simply won't move forward. We will have tons of innovation that simply don't go anywhere. So I think that's the other factor. The other factor I think that's important here, which is not very politically correct, is that there are some things that we know work that simply are not being done elsewhere, but with a bit of top-down push can happen. And there are plenty of examples of that within the National Health Service. Evidence-based medicine is one of them, where there's some things are still not carried out in an evidence-based way despite 10 years of evidence. Or there may be very simple things. For example, how to organise a theatre that simply are not being replicated elsewhere. So there may be some things, because of speed, we need to act quickly through a top-down mechanism. I think that the way to think about spread is to think right at the very beginning of the innovation itself that's being tried. And I think that means absolute scrutiny to the context, and all the factors that can help to make for success or not of this innovation has to be built in from the start. And only with that really granular, fine knowledge of the context as well as the intervention can you then even begin to hope to think about how it could work somewhere else. So there's a certain degree of humility that's involved here, and also heavy attention to behavioural factors, not just technological factors. There's a caricature here, which is that we're still really thinking of innovation like a pill. You give a pill to a person, and the pill is the same no matter where you give it, the person is the same. But actually, innovations aren't like that, and certainly not the way they scale, because the innovations change. The context, as I've said, is relevant. And so we need that humility, and we need to document that before we can even hope to give a best guess about how they can spread. Yes, I think some of this depends on what the imperative is now. What is the perceived imperative to make change? And if there is a big perceived imperative to make change quickly, then I think more risks can be taken. But I think what we're about here is about calculated risks. With something as complex as a service change, for example, if that's the thing we want to do, nobody truly knows what the impact is going to be. You just have to mobilise your best leaders, your best guess. It's a calculated risk, and but we're not able to calculate that risk unless we fully understand the intervention itself and its context.